So I would like to now introduce this evening's speaker, Dr. Copen. If you could turn on your camera and let everyone see your smiling face, that would be great. There we go.
Hello, everyone.
This is Dr. David Copen. He is a cardiologist who is board certified vascular disease, echocardiography, and nuclear cardiology. He joined Inova in 2020 after he received his medical education at Duke University. He did his residency in internal medicine at Duke and then went on to the University of Michigan, where he did his cardiology fellowship. He has been practicing cardiology with Inova Heart and Vascular since 2020 and primarily works at Fairfax Hospital on the inpatient service and sees outpatients in the Boston and the Fairfax office. Dr. Copen, I'm going to let you take it away and educate us, and then I will be back to help facilitate questions that the audience wishes to pose to you. Thanks.
All right. Thank you, Dr. Levy, for that kind introduction. And thank you, everyone, for being here. Hopefully, you can all see my slides. This is a heart failure talk. We're going to go over the definition of heart failure, the causes, the symptoms, and the various treatment options. So what is heart failure? On the most basic level, it's the failure of the heart to provide adequate blood flow to a person's organs. Now, what does that look like? Here are a couple illustrations from the American Heart Association. On the left, you see a normal heart. Let me get my power pointer here. So we have, just to orient you all, we have the right atrium here, which pumps blood into the right ventricle and then out the pulmonary arteries to the lungs. And that blood that is deoxygenated or has low oxygen content gets oxygen from the lungs and comes back to the left atrium, goes through the mitral valve into the left ventricle, and then that pumps blood to the rest of the body. You can see here, this heart is normal in size. The left ventricle here, which is the ventricle we typically talk about when we talk about heart failure, is cone-shaped and contracting well. And the muscle thickness is normal. Now compare that to this dysfunctional heart, where you can see the left ventricle is more globular shaped, kind of rounded shaped. The ventricle is dilated and therefore not as much blood is being pumped to the rest of the body. So that's a good depiction of typical what's called systolic heart failure, or a weakened heart, which is different than diastolic heart failure, which is a stiff heart. And we'll get into some of those specifics here in a little bit as we move on in this lecture. So heart failure is prevalent. There are about 6 million people right now living with heart failure in the United States. And heart failure is a very serious disease. The mortality rate, or the percent of people that are alive at 5 years after a diagnosis of heart failure, or more specifically being hospitalized for heart failure, is about 50%. Here's a map from the CDC looking at the age-adjusted average annual rates of heart failure, dark red being higher rates of heart failure. You can see there's a big concentration of heart failure here in the South and Oklahoma, Louisiana, Arkansas, Mississippi. But a very prevalent disease, a very important disease, and a disease that we have a lot of therapies for. So I alluded to this earlier. There's different types of heart failure. Very basically, we have systolic and diastolic heart failure. And we differentiate these two based on the ejection fraction. So the ejection fraction is the fraction of blood that is ejected from the heart with every beat, as the name would suggest. If a heart, let's say, has 100 milliliters of blood in it, and it ejects half the blood, 50 milliliters, the ejection fraction is 50%. So the math is that straightforward. If the ejection fraction is greater than 50%, we term that a normal ejection fraction. And if that patient has heart failure, we call that diastolic heart failure. Now, there used to just be systolic and diastolic heart failure, but now we have a category in between the two which is technically a type of systolic heart failure, but the ejection fraction is 40 to 50%. And we call that mildly reduced or mid-range ejection fraction. And then we have an ejection fraction of less than 40%, which is termed systolic heart failure. Now, the gap is closing, but in general, there's more extensive research historically on systolic heart failure. But more recently, we have a lot more trials being done in patients with diastolic heart failure. So what are the symptoms of heart failure? The most common symptom is shortness of breath. The medical term for that is dyspnea. So shortness of breath typically is worse when you're doing activities such as walking up hills or up the stairs. Other symptoms of heart failure include orthopnea, which is the medical term for shortness of breath when laying down flat, paroxysmal nocturnal dyspnea, or shorthand PND, which is waking up in the middle of the night short of breath. Patients will often describe waking up in the middle of the night, feeling short of breath, sitting on the side of the bed, and that physical action of sitting up makes them feel better. People will also experience weight gain and fluid retention. This is typically in the legs and feet, but can also develop in the abdomen as well. This swelling in the abdomen can lead to a feeling of satiety or feeling full and decreased appetite. People also describe chest pain, coughing, and fatigue. Now, these symptoms are what we monitor in patients that have heart failure, and there's sort of different levels of symptoms that raise different levels of concern. So if someone's feeling well, and they're not having any new or worsening shortness of breath, your physical activity level is normal. There's no swelling in your legs or feet, or the amount of swelling that the patient does have is normal for them or at their baseline. We ask people to weigh themselves every day because one clue to early fluid retention is that your weight might go up. And so it's really important to track those daily weights and write those numbers down. And so if you're feeling well and not in acute heart failure, your weight will be stable. And you won't have any chest pain. Now compare and contrast that with some mild symptoms or some early warning signs. These include a dry, hacking cough, but intermittent. Worsening shortness of breath with activity. So let's say that you are, typically go for a walk for exercise, and you can complete your walk pretty regularly, except when you get to those hills and you're trying to walk up the hills, you have to rest halfway up, which is unusual for you. Pay attention to that. Swelling of your legs, ankles, and feet. Maybe your shoes feel a little bit more tight than usual, or your pants feel a little bit more tight. Pay attention to that. Sudden weight gain. We typically say about 2 to 3 pounds over the course of a day, or 5 pounds over the course of a week. Unlikely to be something other than fluid, or less likely to be something other than fluid when it accumulates that quickly. Swelling in the abdomen, and difficulty sleeping. And it may not initially feel like clear shortness of breath when sleeping, but just uncomfortable to sleep. And then we get to the warning signs where the cough is more frequent, shortness of breath, not only with activity, but occurring at rest, more severe swelling in your legs or abdomen, where family members will be noticing this or commenting on it. Again, weight gain, confusion, depression, dizziness, loss of appetite, and now a lot of difficulty sleeping, really an inability to lay flat because of shortness of breath, or even sleeping, to a more extreme example, sleeping in a recliner, not even able to lay in the bed. You need to prop yourself up so much. When these symptoms are something that a patient is experiencing with heart failure, they really need to be evaluated right away and contact their cardiologist, or if they are very severe, they need immediate attention, go to the emergency department. Now, what are the different classes of heart failure? The New York Heart Association designated 4 classes of heart failure to help classify patients and determine the best therapies for them, and also help us as physicians be able to communicate with each other in an efficient manner regarding the seriousness of the heart failure. So going from class 1, which is the least severe class, to class 4, the most severe class. Class 1 patients have no limitations of their physical activity. They can do normal daily activities, normal exercise, and don't feel any particular shortness of breath, palpitations, fatigue. NYHA, or New York Heart Association class 2 patients will have a slight limitation in their physical activity. They're comfortable at rest. But normal physical activities such as a brisk exercise or something along that nature will result in some symptoms, either fatigue, palpitation, shortness of breath, chest pain. Patients with class 3 heart failure will have a marked limitation of their physical activity. They will still be comfortable at rest, but usual activities, let's say day-to-day activities in the home, will cause shortness of breath. Climbing a couple stairs or walking around the home, that sort of thing will cause symptoms. And then class 4 patients have symptoms at rest, in addition to any physical activity leading to worsening of those symptoms. Now, heart failure is a progressive disease. We try to slow that progression with our therapies, but I'm going to direct you to this slide to kind of show the typical progression of heart failure. So on the top half of this, we have quality of life. And on the bottom, we have intensity of care. And then on the x-axis, we have time. And so typically, how this progresses is there'll be an initial decompensation or initial symptoms related to heart failure, decrease in the quality of life. And with any decrease in quality of life, we typically intensify care to try to get patients back to their initial quality of life. Now, patients will typically progress slowly, and there's a break in the graph here to show that this could be a variable amount of time. At any point, depending on the type of heart failure, sudden death is always a risk, and we'll talk a little bit more about how to prevent that with therapies. But typically, there will be various decompensations in heart failure, some requiring hospitalization, some not. And with each decompensation, we intensify therapy and try to get a patient back to their previous baseline, but we usually don't quite get back to the previous baseline. And after several of these decompensations, people typically reach the point where we transition to more advanced therapies, such as a heart pump or a heart transplant. Or if there is complete heart failure and no available options for therapy, typically we would then focus on quality of life and palliative measures at that point. Now, the goal is to keep everyone here feeling as well as possible with the therapies that we do have, but it is a progressive disease. So what causes heart failure? I have listed here, the first 3 are the 3 most common causes of heart failure: coronary artery disease, or blockages or partial blockages in the arteries that provide blood flow to the heart itself; high blood pressure or hypertension. With medical therapy for hypertension, this is thankfully becoming less common, as is coronary artery disease, with treatment for risk factors for heart disease, such as high cholesterol and high blood pressure; and then valvular heart disease. Now, this is not meant to be an exhaustive list of all the causes of heart failure, but some of the other common causes of heart failure include arrhythmias, such as atrial fibrillation; toxins, such as alcohol, illicit drugs, and some chemotherapies; myocarditis, which can be due to a virus or sometimes medications. This is inflammation in the heart muscle itself. There are also genetic conditions, which are termed familial types of heart failure, or cardiomyopathies, a problem with the heart muscle. Some specific ones that I've put in here are hypertrophic cardiomyopathy, or a thickening of the heart, dilated cardiomyopathy, or Fabry's disease. And then lastly, infiltrative diseases such as amyloidosis or sarcoidosis. These are diseases where the disease process is actually deposited in the heart muscle. Amyloidosis is important. You guys may have seen some commercials pointing this out, that this is an underdiagnosed condition in many older patients with diastolic heart failure, and something that we actually have a decent number of therapies for now. So important to recognize this. Now, in general, there is general treatment for both systolic and diastolic heart failure. Then there also are specific treatments for the specific causes of heart failure. So it's important to try to figure out the exact cause of heart failure if possible. Now, the way we do that is by a medical history and physical exam, which typically points us in the correct direction and often will give us the diagnosis. Other tests that we do to look for the cause of heart failure includes an EKG, or an electrical snapshot of a patient's heart, looking at those arteries around the heart to look for coronary artery disease with a catheterization, a CAT scan, or a stress test. We'll do an echocardiogram, or an ultrasound of the heart to try, which will help us determine the exact cause in many cases. Some patients may benefit from wearing a heart monitor to look for arrhythmias as the cause of heart failure, some basic blood work, and then in a select few patients, genetic testing or even a biopsy of the heart. Now, here's an overview of the treatment of heart failure, and we're going to go through each of these in some detail to try to give you a better sense of how we treat heart failure. So lifestyle changes are very important. In general, we recommend frequent, moderate exercise. Typically, this is on the order of 150 to 300 minutes of exercise per week, which usually works out to about 30 to 60 minutes of exercise about 5 days per week. For patients that are overweight, weight loss is very helpful in reducing the amount of stress on the heart and improving symptoms of heart failure. Quitting smoking, if patients do smoke, is very, very important. Minimizing alcohol intake. Even if heart failure is not due to alcohol, alcohol itself is a toxin to the heart. And if the heart muscle is weakened to begin with, giving it a toxin is certainly not going to be helpful. There's no safe level of alcohol for patients with heart failure. So I've got weight loss in there again, so it's very important. Getting enough rest, managing stress, and eating a heart-healthy diet. Typically, we recommend a Mediterranean-style diet where, for example, protein is coming from chicken and fish, minimizing carbohydrates, in particular simple carbohydrates like sugary drinks, candies, desserts, that sort of stuff, but also minimizing breads, pastas, etc., and maximizing vegetables that are high in fiber and legumes. So now going through each one of these classes of medications in some detail, we have first diuretics. So all of these diuretics work by removing fluid and removing congestion to help improve symptoms. The specific diuretics that we use are listed on the screen: torsemide or Demodex, bumetanide or Bumex, furosemide or Lasix, and metolazone. The side effects associated with these, as you may expect, could be dehydration if we take off too much fluid, low blood pressure, electrolyte abnormalities, in particular low potassium, and sometimes kidney injury. In general, these medications are for symptom benefit and do not carry with them a survival benefit, but very helpful for symptoms. Next, we have beta blockers. There are really only 3 beta blockers that are effective in heart failure, and these are actually likely only beneficial in systolic heart failure, typically not beneficial in diastolic heart failure, unless there's another particular reason to be on a beta blocker. I typically do not use beta blockers in patients with diastolic heart failure or a stiff heart. Carvedilol, metoprolol, bisoprolol are their names. How they work, they lower the blood pressure and the heart rate to reduce stress on the heart. And side effects include dizziness and fatigue. Next, we have the angiotensin receptor and neprilysin inhibitor, short name ARNI. The one on the market is called Entresto. It's a combination of valsartan, which is an angiotensin receptor blocker, and sacubitril, which is a neprilysin inhibitor. So this medication works by relaxing blood vessels, enhancing fluid removal, and through its effects on hormones in your body, it strengthens the heart. You can use what's called an ACE inhibitor or an ARB, an angiotensin receptor blocker like valsartan alone without the sacubitril, but in general, it's less effective than having the sacubitril in there. Side effects include dehydration, low blood pressure, and high potassium. And this medication is beneficial definitely in systolic heart failure and also likely beneficial in diastolic heart failure. Next, we have the mineralocorticoid receptor antagonists, or MRA. The 2 most commonly used ones on the market are spironolactone and eplerenone. These work by promoting fluid removal and block a hormonal pathway similar to the other medication we just spoke about that's deleterious for the heart. Side effects include dehydration, high potassium, and for spironolactone, one side effect in particular is called gynecomastia, which is breast tenderness. This will typically resolve with termination of the medication, and in this situation, we can very easily switch from spironolactone to eplerenone. Now, these medications also are likely beneficial in systolic and diastolic heart failure. Next, we have the SGLT2 inhibitors, or the sodium glucose cotransport 2 inhibitors. These are empagliflozin, dapagliflozin, and canagliflozin. Initially, these were developed for diabetes, and they work by increasing sugar excretion in the urine. But they've been shown to be beneficial in heart failure as well. These are both beneficial in systolic and diastolic heart failure. And the more we study these drugs, they seem to be beneficial in many other chronic conditions as well, in particular, chronic kidney disease. Chronic kidney disease and heart failure often go together. So these medications are very helpful. Side effects include dehydration. And as you can imagine, if there's more sugar in the urine, UTIs and yeast infections. Next, we'll get to some device-based therapies. We'll go through each of these. I have a few animations. So first, in patients that have either had arrhythmias or have a severely weakened heart, a defibrillator, which is a small device placed underneath the skin with wires that go into the heart, can be life-saving. So how these work, let me get my pointer off here. When the device detects an arrhythmia, it can deliver a shock to get the heart out of that arrhythmia. I'll play this again here. You can see there's an arrhythmia here, and then the device shocks back into a regular rhythm. In certain patients with an abnormal conduction system called a left bundle branch block, we can use something called cardiac resynchronization therapy, which essentially reorganizes the electrical signal in the heart. Now, this is essentially a particular special type of pacemaker that has a couple of wires that go into the heart, and takes over that electrical system and paces it in a more natural fashion as opposed to the abnormal fashion that is the left bundle branch block. Next, we have coronary stents and bypass. So for patients that have coronary artery disease, we can bypass those arteries to provide blood flow to the part of the heart that is not getting enough blood flow. This is a representation of the different coronary arteries, the right coronary artery, left anterior descending, left circumflex here going behind the heart. And I'll show you what this looks like. So we access the arteries either through the femoral or radial artery, advance a catheter up into the heart, inject contrast dye down the heart, and you can see here is a representation of the coronary arteries. And here, there's not normal blood flow. There's a blockage here. You can see that area of contrast is thinner than the rest. And so then what our interventional cardiologists can do is they can find that blockage and advance a wire across that plaque. And then along that wire, advance a balloon, inflate the balloon to push the plaque out of the way. And then to provide a durable result, next we can place a stent, which is represented here as this wire frame. And that will then improve blood flow down that artery. Now, for people with multiple blockages or disease that cannot be adequately stented, we can perform, or the cardiac surgeons can perform a bypass graft. So here's a representation of that, where you have the aorta coming off here, and then this is a vein graft from the leg, a saphenous vein graft, grafted onto the aorta, and then grafted onto the coronary artery here, distal to that blockage to provide blood flow to the heart. Next here, for patients that have valve disease, which is responsible for their symptoms or heart failure, one really exciting treatment that we do quite a bit of at Inova is called a MitraClip to help with mitral valve regurgitation. And here's an example of that. Oops. So the interventional cardiologist, the structural cardiologist, will advance a catheter up to the heart, cross the septum of the heart. And here's a representation in the cath lab of the catheter here going across the septum. And this is a transesophageal echo taking pictures. And so now what they're doing is using this MitraClip device, advancing it across the mitral valve. And you can see here, there are these two grabbers on the side, and watch how they extend and grab the mitral valve and clip it together. So now instead of this section of the valve prolapsing back into the left atrium and causing significant mitral regurgitation or leakiness, it is now clipped together. There are other types of procedures that can help with valve disease as well. And a whole team of cardiologists, the general cardiologist, the structural team, and the surgeons will often work together to figure out the best way to treat a patient's valve disease. So here we have a representation of an annuloplasty ring, or a ring that goes around a leaky valve. It cinches it together to help prevent regurgitation. Here's an example of a prolapsing segment or defective segment of a valve that is excised and then sewn together along with a ring to help reduce regurgitation. And of course, there can be valve replacements as well. So I mentioned arrhythmias can cause heart failure. Atrial fibrillation is a particularly important one because it is associated with heart failure, and we have really good therapies for it. In particular, an atrial fibrillation ablation, where the electrophysiologist, the heart rhythm doctors, can use catheters to actually ablate or burn or freeze a portion of the heart that is causing the arrhythmia to stop atrial fibrillation. And then we get to some more advanced therapies. This is a pulmonary artery pressure monitor that actually goes in the pulmonary artery, which can measure pressures in the heart and try to pick up on fluid retention earlier than even potentially some of the other monitoring methods that we spoke about before, such as weighing yourself or looking for swelling. About 10% of heart failure is considered advanced heart failure and should be treated by an advanced heart failure specialist. So I'm a general cardiologist, but we have a whole team of advanced heart failure doctors that can help take care of patients with more severe or advanced heart failure, those that are not responding to our traditional therapies. Now, some different reasons to consider seeing an advanced heart failure doctor are listed here. So if the ejection fraction remains severely reduced, less than 30%, if there are severe symptoms that are refractory to medications, multiple hospital admissions in a year, a significantly or severely dilated heart, an inability to tolerate medications, either due to multiple side effects or very low blood pressure, or other organ dysfunction, such as kidney dysfunction or liver dysfunction. Some of these patients with severe heart failure may be considered for advanced therapies, which the two most common types of advanced therapies are a heart pump called the left ventricular assist device, or LVAD, or a heart transplant. Now, just very briefly, this is a representation of a left ventricular assist device. So the pump itself sits here at the apex of the heart with one cannula going into the left ventricle. And this will remove blood from the left ventricle, go through the pump, and then deposit it in the aorta. So essentially bypassing the left ventricle, which this deposits blood with pressure. This is controlled by the system controller and the drive line. And this whole system is powered by batteries. And then lastly, patients with very severe heart failure may be considered for a heart transplant, where the actual heart is removed and replaced with a donor heart. In general, the outcomes with transplant are favorable, with half of patients that get a heart transplant living to 10 years, and of that half, many will live much longer than that. And we have an excellent transplant team at Inova that has a lot of experience. This is my last slide, a little bit of a busy slide, but I don't want to go through all of this, but it just goes to show you all the various therapies that we do have for heart failure, and that it really takes a team of folks to help coordinate all these therapies and to think about when to use them all. And we're happy to walk you through these if you do have heart failure. And with that, I would like to thank you for your time. This is the main office that I see patients at the Inova Center for Personalized Health in Fairfax. That's my office phone number. And here's a website that has a list of all of the cardiologists at Inova. Thank you.
That was outstanding, Dr. Copeland. Thank you very much, but we're not going to let you off the hook yet, because we got a whole bunch of questions that have been put up in our Q&A box, and I probably have a few myself. So I'm going to try to group them into kind of topics, and I think we'll start with weight, since there were a lot of questions about weight, like how much weight gain is bad, and is all weight gain heart failure? And when do you break the glass? When do you push the button? Can you quantify? I know in your talk you were talking about 5 pounds in a few days, or 5 pounds in a week, or 2 pounds in 24 hours. Do you think patients who have a history should be weighing themselves every single day?
I do, yes. I think that patients with a history of heart failure should weigh themselves every day at a consistent time with the same amount of clothes on to give them a baseline weight. And then they can write that down and use that to see if there's any trend that would suggest fluid retention. Like you said, we typically use about 2, 3 pounds in a day or 5 pounds in a week to suggest that fluid is being accumulated, because typically you don't gain that much weight just from food or other activities. But I do also tell patients to use their judgment and some common sense as well, where if you gain 1 or 2 pounds, but then you also notice swelling and shortness of breath and other symptoms, take that seriously and contact your doctor. Or if you did have a particularly large meal and you otherwise feel great with no other symptoms of heart failure, and then you weigh yourself the next day and the weight's back to where you were, probably let that one slide. But if there are any areas of confusion, you can always call your cardiologist's office and get their advice.
Great. I'm going to sort of put a couple of questions together with questions that patients have asked me over the years, because I think all of us can understand the concept of heart failure when you have a weak heart, right? The heart's weak, pressure and fluid backs up into the lungs, down into the legs. But how do you explain heart failure when you have a good, strong heart? And some people ask, well, what's systolic or diastolic heart failure? If you choose, but more importantly, how do people have heart failure when they have a strong heart?
That's a good question. So you're referring to diastolic heart failure or heart failure with preserved ejection fraction? So I like to think of that as a stiff heart. So both in patients with a weakened heart and a stiff heart, most of the symptoms of heart failure come from elevated pressures in the heart and excess volume. And even if the heart is strong, the pumping function is normal, the pressures can be significantly elevated due to that stiffening of the heart.
Yeah. By the way, there was a request put in very early in the talk, and I think it's a great request, and I'm not expecting you to answer it, but I'm just going to make you aware of it. Someone put up there saying, I really need like a handout to give people to explain what heart failure is. And this is like for family members and patients who have heart failure, because it's a hard thing to explain to folks exactly what it is, certain foods are important, why certain activities are limited. I don't particularly know of something that is that patient friendly. If you do, that's great. But otherwise, I think it's certainly something we can put on our to-do list.
Yeah, I mean, I would say a lot of the animations that I got from today's talk are from heart.org, from the American Heart Association. And they have a whole list of topics that are very friendly in terms of their language and descriptions. And I think that's a good place to start. You can click through essentially all those topics at your leisure. And then if there are questions, I often ask my patients to write down their questions and bring them with them to their appointment so I can answer them.
Sure, that's great. Someone brought up a really good point. A class of medication you didn't talk about, questioned about the GLP-1s, the new weight loss drugs, the Ozempics and the Wegovy's. And I think there has been some talk about they can be beneficial in the setting of congestive heart failure. Do you have thoughts about that?
Yeah, no, I think they definitely are. The Select trial just came out, which showed some really promising results with that class of medications. Um, I think it's hard to tease out how much of that benefit was from the weight loss itself versus the medications. But those are definitely medications that we need to think about using more frequently in the future as cardiologists. Um, Currently I think they're mainly prescribed by endocrinologists for patients with diabetes and primary care doctors and weight loss specialists. But I think those are excellent medications.
Um, I'll throw you a lowball question here. Someone wanted to know red wine. Is red wine good for the heart, Dr. Copen?
No, I don't think so. I think if someone has heart failure, there's no amount of alcohol intake that is acceptable. I typically tell my patients to avoid it if possible. An occasional drink here and there is not the end of the world, but alcohol itself is a toxin, so I would avoid it if you have heart failure.
This is one I hear a lot, and there's some questions coming up about blood pressure. A lot of times patients are afraid to take some of their heart failure medicine because they think that their blood pressure is low. Is low blood pressure a problem when you're taking heart failure medications, or is low blood pressure a good thing?
Yeah, it's a good question. I think the answer is how low and what sort of symptoms are associated with it. So I would say in general, a systolic blood pressure down to 100 is perfectly normal in someone with heart failure and should not prevent them from taking their heart failure medications. A lot of the blood pressure medications that are used for heart failure, part of how they work is they decrease the resistance that your heart has to pump across, which technically can lower blood pressure in people's whose hearts are pumping at the maximum efficiency to begin with. But if your heart has room to pump better, some of these medications that are traditionally blood pressure medications will have no effect on the blood pressure. Your blood pressure may be 100 to begin with. You take the medication, it's 100 afterwards. Now, if someone has symptoms, lightheadedness, dizziness, feeling like you're going to pass out, then a blood pressure 100 or lower can be very serious and can limit the number of medications, the types of medications that they will tolerate. In general, we like to keep our patients with heart failure, keep their blood pressure on the lower side between 100 and 110 systolic, while we maximize these medications that we know are beneficial to heart failure long term.
And the reason is that will maximize their cardiac output, the amount of blood flow that will get to the body, right?
Spot on. Yep.
Yeah. So another class of medications there were questions about, and this is a great one, like, hey, my sugars are normal. My doctor, wants me to take this Jardiance or something that's really a diabetes drug. Why should I do that? Is it going to make me, hypoglycemic? Is it going to drop my sugar tremendously?
In general, they will not drop the blood sugar tremendously. There certainly is a small risk of hypoglycemia or low blood sugar, but that's really not where the benefit in these medications lies. And even if you do not have diabetes, we've studied this medication in people with just heart failure, both reduced ejection fraction or systolic heart failure, or preserved ejection fraction or diastolic heart failure. And they are beneficial even if you did not have diabetes. You definitely want to be careful and make sure that you look out for signs of low blood sugar, but most people do not experience that as a side effect.
Great. A bunch of questions about atrial fibrillation, Dr. Copen. And I know this isn't an atrial fibrillation talk. We have atrial fibrillation talks as part of the series of Ask the Expert. And I would encourage everyone to come back who has an interest in atrial fibrillation. But some of the questions were like, well, what's your favorite drug? And there's no answer to that. After a cardioversion, how likely is it that I'm going to go back into atrial fibrillation? Atrial fibrillation and heart failure, what can you say about it in a nutshell without getting into an AFib talk, maybe about rate control and things of that nature?
Yeah, I would say in general for patients with heart failure, a rhythm controlling strategy, meaning that we are trying to maintain sinus rhythm or normal rhythm and keep patients out of atrial fibrillation, that is the preferred strategy. There are several recent trials looking at rhythm control, both with drugs and ablation, and all the evidence is pointing towards a rhythm controlling strategy being beneficial long term from a heart failure and mortality benefit. And it seems like an ablation is the preferred method, assuming the patient is a candidate for an ablation.
Hey, David, do me a favor. Could you stop sharing your slides because we'll be able to see you better?
Oh, yes.
Would be
Yeah.
great. Um, a bunch of questions about coronary disease and our calcium scores and coronary stents. Let's start with one that, a patient has a moderately elevated coronary calcium score. They don't have symptoms. They've been told to be put on a statin, a cholesterol lowering medication. What else? Is there anything else they should be doing besides that?
Yeah, I would say probably the couple of most important things to be doing other than taking medication like a statin, which does have the capability of preventing new plaque from depositing and stabilizing plaque, would be to adhere to a heart healthy diet, like I'd mentioned before, a Mediterranean style diet, regular exercise, and then weight loss. Those are all things that are going to help dramatically with cholesterol. A lot of cholesterol, though, is genetic, and unfortunately, we can't change your genes to create a more favorable cholesterol profile. So in addition to those lifestyle changes, the medications are essential.
And would you also recommend a low dose enteric-coated aspirin for patients who have an elevated coronary calcium score?
That is a hard question. So I would say that is very individualized, and depends on the patient's bleeding risk, because aspirin can increase the risk of gastrointestinal bleeding. And so I would say in general, if your bleeding risk is low, if you are relatively young, let's say less than 70, and you have a very high calcium score, greater than 100, then typically, yes, I would recommend aspirin. But you really need to talk to your doctor about that one, because there are lots of specifics.
That's the key. Talk with your doctor. There was a great question, and I think this is interesting. So when we manage patients with coronary disease and hyperlipidemia, one of the sort of subfragments of lipids we look at sometimes is what's called LP little a. But one of the questions was, is there any evidence that LP little a has any role in the development of heart failure?
No specific evidence that I'm directly aware of, but certainly LP little a leads to an increased incidence of coronary disease, which is the most common cause of heart failure. And so if you have elevated LP little a and heart disease, treating that will be important to prevent heart failure. But I'm not aware of any specific trials looking at LP little a and heart failure.
Yeah, a couple of people, and I really feel for everyone who has any chronic disease, but heart failure is a chronic disease, and generally we don't cure heart failure. We try to manage heart failure, but people are struggling with what to tell their families. You know, and I think I'm not even sure how to ask a question about, but I guess the answer is work with your doctors to be able to come up with as good an explanation and prognostic discussion as is possible. But none of us have a crystal ball, and we never know when people are going to progress or stay stable for years. I mean, and I know I'm the host, you're the speaker, but I've been practicing cardiology for a long time. Patients who have ejection fractions of 10%. That means only 10% of the blood each time it squeezes, and they've been doing fine for 15 years on medical therapy. So you really just never know. You just never know. Do you have the other question about coronary disease and stents? Some folks wanted to know, if you've gotten a stent, what's going to stop blockage again, just like in the native vessel?
So in terms of stopping a blockage in the stent, for the first 6 months to a year after getting the stent, it's important to take the antiplatelet agents, usually aspirin plus another what's called P2Y12, or I colloquially will call it a super aspirin like ticagrelor or clopidogrel. And then long term, really the medications that we have been talking about, the statins and other cholesterol lowering medications, in addition to living a healthy lifestyle, exercising, weight loss, no smoking, that sort of stuff.
Yeah, I'm going to apologize because we're not going to get to all the questions. There are a lot of questions, and that shows a lot of interest out there. I will answer one of them. Someone asked whether they can get a copy of your slides. The recording of this webinar will be available and will be sent to you, and all of the slides will be included in that presentation. So you will be able to see all the slides again. That's not a problem. Let's see. I had another question. You know, below what blood pressure should people really reach out and contact their physician? Some folks are really concerned about, someone mentioned like a blood pressure of 60 over 30. Would that concern you, sir?
Oh, for sure. Yeah. I mean, I think in general, people should be worried about a blood pressure consistently of less than 90, unless they're told by their doctors that in their specific case it's okay. And certainly anything below 90 with symptoms, reach out. And I would say anything below 80, even without symptoms, definitely reach out. Blood pressure of 60, you're probably heading to the emergency department.
How about the relationship between sleep apnea and heart failure? Is there one?
Yeah, I think there is an association between the two. Sleep apnea is associated with significant cardiovascular morbidity and mortality. Um, it's associated with high blood pressure, associated with high blood pressure in the pulmonary arteries or pulmonary hypertension, associated with atrial fibrillation, pretty much everything we spoke about during this presentation. So if a patient has symptoms of sleep apnea, loud snoring, witnessed apneas, or actually someone's witnessing you stopping breathing for seconds while you're sleeping and then breathing quickly after that, very important to tell your doctor about that and get a sleep study. Treatment can not only make you feel better, but help you live longer.
How about cardiac rehab? We hear about cardiac rehab. It's a program that's present in many hospitals. Has that been shown to be beneficial for heart failure patients?
Yes, cardiac rehab is definitely beneficial. I think a lot of patients like it too. It's a regimented, monitored exercise program to both show people the types of exercises that they should be doing and monitor them during those exercises. So it gives people confidence, and does help build cardiopulmonary reserve and muscle mass and endurance as well. So very, very helpful. And then after you finish cardiac rehab that the insurance pays for, continue to do those exercises on your own once you've graduated from cardiac rehab.
Thank you. I'm going to remind folks, a bunch of you are putting in questions which are pretty personal to your health and sort of specific questions that we really can't answer here. And I encourage you to address those to your physician or make an appointment to see one of our cardiologists. Here's a question for you. So if I have a diagnosis of heart failure, but I'm pretty well compensated, meaning I'm not having a whole lot of symptoms, are there things in my life that I shouldn't do? Can I go out and play golf? Can I babysit my grandchildren? Can I have sex? Are there things that are like, whoa, don't do that. You're putting yourself at risk.
Yeah, for people that are generally feeling well, not having symptoms with the activities that are in question, I typically tell them that they don't have any artificial activity restrictions, that you're free to do the types of exercises that you would like to do. I usually qualify that by saying that in general, from a cardiovascular and heart failure perspective, that intense exercise is not any better than moderate exercise and increases the risk of injury. And so I typically ask patients to preferentially do moderate exercise.
Right.
Some specific, types of heart failure where you would want to avoid intense exercise, like hypertrophic cardiomyopathy. But if you have one of those things, your doctor should be talking with you about any specific activity restrictions. So you can always ask your doctor just to make sure.
Something that I don't think we touched upon that people do ask, patients ask a lot is there a strong family history? If I have heart failure, do I need to be concerned about my children, my grandchildren? Is that something that family members should be tested in some way for?
Yeah, I would say, I mean, if you have a genetically inherited mutation or condition, a specifically named one, you can ask your cardiologist how that's inherited, and if it is inherited in a way that your children may get it, definitely they should be tested. For the most part, genetics can get kind of confusing, so talking to your cardiologist or geneticist is really helpful. I would say generally, though, for people that don't have a known genetic condition, if you were diagnosed with heart failure at a young age, let's say less than 50, that raises the possibility that it is a specific genetic condition that you could pass on. But I would tell your family members about your condition, about heart failure, so they can at least share that with their doctors, to see if further screening is recommended for them.
Sure. And another common question, and this may have to be our last one, this is about statins, cholesterol lowering medications. And a lot of times patients are a little hesitant to start a statin because they heard or read somewhere that there's a lot of side effects. How common are side effects from statins? And, do they lead to any kind of permanent muscle damage?
Yeah, so I would say in general, the damage is not permanent. The incidence of muscle problems or myalgias that you would kind of feel like you get with the flu, that's what people describe when they get statin related muscle problems. In general, when we look at patients that are getting a statin versus placebo, the incidence of side effects is fairly similar. But there definitely is this known side effect of statins, probably in about 5% of people. Keep an eye out for them. If you do get them, we have multiple other statins that we could try. Many people get myalgias with one type and not with others. And then we also now have multiple different classes of medications that work really well to lower cholesterol that are unrelated to the statin. So if you do try the statin, get a side effect, we can always stop it, reassess, and use a different class of medications that does not have that type of side effect.
Excellent. And there are about 100 more questions that we're not going to get to, but thank you so much, Dr. Copeman, for being here with us this evening. I think we've all learned a lot.